Welcome everybody to the West Oncology Conference. Today we'll discuss EGFR resistance mutations and the roles of antibody-drug conjugates in non-small cell lung cancer. I'm Shayma Kazmi. I'm the Medical Director of Thoracic Oncology at Cancer Treatment Centers of America in Philadelphia. These are my disclosures. Today's learning objectives, we are going to review the current treatment options for patients with EGFR mutation positive non-small cell lung cancer and resultant therapy resistance. We'll discuss the antibody-drug conjugates and their evolving role in patients with EGFR-resistant non-small cell lung cancer. We'll explore the new transmembrane marker TROP2 and its role in tumorigenesis and potential targeted agents to inhibit its effects in patients with non-small cell lung cancer. So let's get right into it. We'll go through the history of EGFR mutation positive advanced or metastatic non-small cell lung cancer. We know that EGFR facilitates targeted treatment in advanced non-small cell lung cancer. And whether we test that on tumor tissue or ctDNA, it provides a great target. Acquired resistance, though, in first and second generation TKI therapy, which can be detected by plasma monitoring of ctDNA, is a growing concern. We know that EGFR T790M mutation is one of the most frequent resistance mechanisms at progression. Acquired resistance to third generation TKIs in first and second line is also emerging to be a problem. The potential mechanisms here are different EGFR mutations, single nucleotide variants, MET amplification, HER2 amplifications, and genetic fusions. So early detection of these mutations involved in resistance may help further stratify our treatment decisions. So this is the current EGFR-TKI landscape. The first generation agents we know are Gefitinib, Erlotinib, second generation are Erlotinib and Dacomitinib, and the third generation, the only third generation TKI we have currently is Osimertinib. So let's go through the history of the clinical trials that got us these approvals. IPASS was the original clinical trial with Gefitinib, which was compared to standard platinum and taxane chemotherapy at that time. And they did not at that time exclude EGFR mutation negative patients. This was the first realization that EGFR mutation positive patients responded to EGFR targeting TKI. So as you can see, the PFS curve on the left is for patients who had EGFR mutations. And as you can see, Gefitinib was superior to carboplatin and paclitaxel with a hazard ratio of 0.458, which was statistically significant. However, this response was not seen in patients who did not harbor an EGFR mutation. Moving fast forward a couple more years to Erlotinib. So the Erlotinib clinical trial, this was the optimal clinical trial that was done in China on the left, and then the EuroTac trial on the right, very similar sort of trials with Erlotinib versus gemcitabine carboplatin on the left, whereas it was taxane and platinum on the right, or they could have used gemcitabine as well. Now, as you can see in both of these trials, Erlotinib was superior to platinum doublet chemotherapy with hazard ratios that were similar and significant statistically and clinically, one would argue. The safety summary of these drugs, as we know, is different than chemotherapy. They don't harbor the classic pancytopenia types of issues that chemo generally does, but infection, skin rash, diarrhea, stomatitis, paronychia are very classic and really class specific. Most of them are manageable. In Erlotinib, as you can see in this trial, the grade 3-4 reactions were in single digits and certainly very tolerable. Moving forward to the second generation tyrosine kinase inhibitors, the Lux-Lung study, Lux-Lung 7 on the left is a phase 2 clinical trial, whereas the Dacomitinib study was the Archer 1050 phase 3 randomized open label trial. And again, both of these drugs were compared to Gefitinib, which was the first generation TKI most used at that time. And as you can see, they proved to be superior in progression-free survival, and both of them had statistically significant results. However, really the uptake of Afatinib and Dacomitinib has not been that great, primarily, as you can see, because of their toxicity. So their toxicities, when you compare it to the first generation Gefitinib, were significantly higher. So you see more grade 3-4 diarrhea, paronychia, dermatitis, acneiform, and enough to cause a significant quality of life issues for patients who may be on these drugs for a long time. They looked at the impact on quality of life in this Dacomitinib study, and as you can see, there's a statistically significant difference in the worsening of the quality of life in patients who received Dacomitinib compared to Gefitinib. So despite the modest improvement in the progression-free survival, it did not really offer any clinical benefit over the first-generation TKIs. Now, what about the combination of TKIs and VEGF inhibitors? We know that the JO25567 study was an open label randomized phase 2 study in Japan, and the progression-free survival for the combination of Erlotinib and Bev was superior to Erlotinib alone. Now, this study did not meet overall survival, and it was not powered to do so. As you can see, the overall survival does cross the threshold of 1 and was not significantly superior. So they designed the NEJ026 study, and this was a phase 3. Again, it was powered for OS, although the primary endpoint was progression-free survival. And so this progression-free survival, as you can see, is superior, although it wasn't as dramatic as the previous study, and unfortunately did not meet the overall survival statistical significance. So the jury's still out in terms of whether EGFR TKIs and VEGF inhibitors should be used, at least bevacizumab should be used as a first-line option. But then we had the relay studies, and this was a fairly large study across 13 countries, worldwide double-blind phase 3 study utilizing Erlotinib and ramucirumab, the other VEGF inhibitor. As you can see, the primary endpoint for relay was progression-free survival, and hazard ratio is 0.591, statistically significant. Now, it has not reached maturity for overall survival. Just so you know, the objective response rate was fairly similar in both arms, 76% versus 75%. And the duration of response was significantly higher in the Ram arm, which was 18 months versus 11 months in the Erlotinib arm. And we await the overall survival data. However, this regimen is FDA approved as an option for patients with EGFR mutations. So moving on to the combination of EGFR TKIs and chemotherapy, what about combining them both? So this was the NEJ009 phase 3 randomized study, and the induction phase was Gefitinib plus platinum-based chemotherapy, or Gefitinib initially. And then they really looked at PFS1, the progression-free survival to the first treatment change, and if patients progressed on Gefitinib, they were recommended chemotherapy, and then their progression-free survival 2 for the second progression was also evaluated. So when you look at this, this is the first PFS, and there is a significant improvement with Gefitinib and chemotherapy versus Gefitinib alone. So the median PFS with Gefitinib was 11 months, and Gefitinib chemotherapy was 20.9 months, and this is significantly improved. However, when you look at PFS2, all of that benefit is lost. All of those patients who had improvement with Gefitinib at their first progression had chemotherapy. Now, survival beyond first progression was also not statistically different. And so they really, felt, so when you look at the overall survival, there is a statistical difference in improvement with Gefitinib and chemotherapy, but the authors really felt that the overall survival really correlated with the first progression-free survival. But all of that is moot. So if you look at that slide that I just showed you of the PFS of Gefitinib with Gefitinib and chemotherapy, when you look at Osimertinib, and so the trial we're looking at on the right is the FLAURA trial, where Osimertinib, the third generation TKI, was compared to standard EGFR TKI, and really the hazard ratio is far superior. And so the idea of combining a first generation TKI with chemo is not favored because Osimertinib certainly has proven itself to be the first and superior agent in the first-line setting. So Osimertinib was first evaluated in the AURA trial in patients who had the T790M mutation because of having been treated with the first-generation TKI. So on the left, you can see that the full intent to treat population, all of them had the T790M mutation, had platinum pemetrexed chemotherapy or Osimertinib. And as you can see, Osimertinib had a PFS that was 10.1 months versus chemotherapy was 4.4 months. And this was statistically very significant. And when you looked at the patients who specifically had CNS metastases, OC fared significantly better as well. And so the FLAURA study was a first-line study where OC was compared to a standard EGFR TKI of the physician's choice, and it was either Erlotinib or Gefitinib. And the PFS Kaplan-Meier curve you can see on the left is OC Median PFS was 18.9 months and standard EGFR-TKI 10.2 months with statistical significance and a hazard ratio of 0.46. Overall survival was also significant. It is actually not quite even reached the median yet. When you look at patients in the FLAURA study with CNS disease, OC again fared better with a median PFS in patients with CNS 15 months versus standard TKI of 9.6 months. Even with patients who did not have CNS metastases, they fared significantly better with Osimertinib. So really, when you look at the PFS curve and then you look at the forest plot on the right, you can see that pretty much any subgroup favored Osimertinib over a comparator EGFR-TKI. And there's really no question, age, sex, race, Asian, non-Asian, CNS metastases, performance status, and none of that seemed to matter. The type of EGFR mutation also didn't seem to matter, and OC fared superior. And so the FLAURA overall survival just barely reached the statistical significance for overall survival. Safety summary. So we know that the second generation TKIs are slightly more toxic than the first generation TKIs. Osimertinib seems to be comparable, if not maybe slightly even better tolerated than the first generation TKI. So as you can see, these are the AEs. The light pink and the light green are the grade, all grades AEs, and then the darker orange and the darker green are the grade 3-4 AEs. As you can see, Osimertinib has some diarrhea, anorexia, ALT increase, and rash and acne, but single digits when it comes to the grade 3 and 4 events. Certainly, 2/3 of the patients will have some degree of diarrhea and rash. All of that seems to be manageable, very similar to a first generation TKI. So what's the impact to clinical practice? We know Osimertinib is a standard of care first-line treatment in the US. It's got better progression-free survival, CNS penetration, side effect profile. The FLAURA updated data further support this with the overall survival benefit. And so the idea of sequencing first-generation TKI and saving OC for later is really not supported based on this data, but will vascular endothelial growth factor chemotherapy added to Osimertinib improve outcomes? We'll have to wait for the future studies. They're actually ongoing to give us that data. Now, we know the resistance mechanisms to first-generation Osimertinib is a real issue. These are many. It's not something as simple as a T790M mutation, which was almost easier to target. So these are the multiple resistance mechanisms. 40 to 50%, we really just don't know what they are. 15% of these are transformations to small cell lung cancer or squamous cell cancers, which are going to be treated completely differently. But as you can see, the 6 to 10% of them could be the acquired EGFR mutations. There's MET amplifications. There's acquired oncogenic fusions, RET, BRAF fusions. You can also see the MAPK PIK3CA mutations that could well be targeted. We know that EGFR, HER2, and ErbB collaborate within a framework of a layered signaling network. And this is highly complex, but we know that when patients are treated with an EGFR blocking agent, the other pathways are going to be upregulated to compensate for this. And so targeted therapy to EGFR can lead to HER3 overexpression. HER3 can't be autophosphorylated, but HER3 dimerizes with EGFR, which activates then the pathway previously inhibited by the EGFR-TKI. And this is a well-known mechanism of resistance. So HER3 expression on cells can serve as sort of a door to the cell for cytotoxic therapy in the form of antibody-drug conjugates. So the U3-1402 is a type of an antibody-drug conjugate, the anti-HER3 antibody. It's got a linker, and then it's got a payload, which is ultimately going to be cytotoxic. So how antibody-drug conjugates work is ADCs bind to the surface receptor and leading to endocytosis, and there's lysosomal degradation within the cell that breaks the linker and releases the cytotoxic payload. And some of the preferred qualities of an ADC is higher drug to antibody ratio. This deposits more drug into the cell. The payloads that are membrane permeable may lead to bystander effects by entering the neighboring cells after release from the first targeted cells. So all of this caused more cytotoxicity, more cell kill, and this is what's preferred. GSK 2849330 is another one of these ADCs. It's an IgG1 GG3 glycoengineered humanized monoclonal antibody. And it's engineered for 3 mechanisms of action: the blocking the ligand-dependent signaling, inhibiting HER3 signaling and function, and cell-mediated cytotoxicity, which is very important. There's also complement-dependent cytotoxicity of the neighboring cells. And this demonstrated compelling preclinical data targeting HER3. Coming back to the U31402 drug, it now has a name, Patritumab Deruxtecan. The features of this HER3-directed ADC is that it does have the high potency of the topo-1 inhibitor payload. It has a drug-to-antibody ratio of about 8:1. The payload has a short systemic half-life, and it's membrane permeable, allowing entry again into the nearby cells, giving the bystander effect that we desire. So the study schema for Patritumab Deruxtecan phase 1 dose escalation study is here. Eligible patients had metastatic unresectable EGFR mutant non-small cell lung cancer. They had to be T790M negative after first or second generation TKIs or having progressed on Osimertinib. They did need pretreatment tumor tissue for retrospective analysis of HER3 expression. So this was a dose escalation study, and patients received anywhere from 3.2 milligram per kilogram upwards of 6.4 milligram per kilogram. And this is 23 patients, 16 are ongoing, 7 have discontinued. And the dose expansion study will enroll additional patients at the recommended dose. And so this is the diverse resistance mechanisms and the anti-tumor activity across all of these resistance mechanisms that was interesting. So this is the best percentage change, and as you can see, based on the color schema, the C79S, for instance, is the purple. Every patient with that dose had a resistance with the C79S mutation and a response. The dosing is also listed there. And so the idea is to be able to target multiple mutations at once, since that seems to be the complex way of resistance with Osimertinib. The anti-tumor activity over time, you can see it's a wide array. It's not clear whether the higher doses is the most effective. As you can see, patients in green, which have the 3.2 milligram per kilogram, also have continued and sustained responses. As you can see here, this is the treatment durations. All the patients, these are individual patients. All the patients with the arrows have treatment ongoing. These are color-coded based on their dosing. As you can see, patients either had stable disease, partial response, or progressive disease. And you can see that there are a significant number of patients with treatment ongoing, quite a few for a long time, moving on to about 48 weeks at this time. Of course, the treatment-related adverse events are going to be really important in the phase 1 study. And really what appears to be a dose-limiting toxicity is low platelet count. So, thrombocytopenia, neutropenia, nausea, those are the things that they most are concerned about. Grade 3 febrile neutropenia did occur in one patient in the 5.6 milligram per kilogram dose. Grade 4 platelet count of thrombocytopenia occurred in basically 3 out of 5 in the patient's 6.4 milligram per kilogram dose. So this will allow them to figure out the dose for the expansion cohort, which they picked to be 5.6 milligram per kilogram. 49% of these patients had CNS metastases, and HER3 was checked and expressed in nearly all tumors. This was a heavily pretreated cohort. Median prior regimens were 4. Some of them had up to 9 anti-cancer regimens prior to enrollment. 90% of them received prior platinum. And median prior EGFR TKIs were 2, and then some of them had even 4 agents prior to having this drug, and 86% had received prior Osimertinib. The median treatment duration was 3.5 months, and overall safety and tolerability was as expected based on the phase 1 trial. These are the results. Again, small numbers. 1 out of 56 patients had a CR, 13 had partial response. Stable disease was really 45% of the group. So confirmed overall response rate was 25%, and disease control rate, which includes stable disease, was 70%, and duration of response was 6.9 months in this heavily pretreated group. And these resistance mechanisms included EGFR C797S, MET amplification, HER2 mutations, BRAF fusions, and PIK3CA mutations. So really, these are the take-home points. EGFR story is really long from over. Sequencing strategies continue to evolve. The Osimertinib currently is the strongest first-line contender for treatment. OC plus VEGF inhibition, OC plus chemo, and multiple other combinations are being evaluated first-line presently, and we're looking forward to some of those results. Osimertinib in the adjuvant setting will complicate the issue even more. It will certainly really need us to require other fourth generation and beyond TKI options for patients when they relapse. Antibody-drug conjugates and HER3 targeting is a novel mechanism for EGFR resistance. Thank you.